Goodness, sorry. Uh, this is my first time actually ever live streaming on YouTube. And actually, I was trying to do something super slick or super cool, using another program so I can show you pictures and I can show you some drawings. And that one wasn't working. So then I had to scramble, try to get back onto YouTube Studio. So if it's just us three, well, that's fine. We can talk. Oh, maybe Mike. Thanks, Mike. Um, yeah, I'll try to do better next time. If there is next time, I guess we'll find out once we kind of go through this whether it's useful to be to do it again. I did a Facebook Live about um, probably a year and a half ago or so. For whatever reason, the Facebook Live was easier, but I'm on YouTube more than Facebook these days, so I thought it'd be better. Okay, Lushar, is that how you say your name? I'm glad you're here too. Hope maybe somebody will come back on, or we'll do a better job and um, get it on time next time. Um, okay, so where are y'all coming from, logging in from? Another part of my interesting thing is I had forgotten I had another appointment, so I'm actually streaming from my brother-in-law and sister-in-law's basement. Lushar in New Jersey, nice. How about Maria? England. Wow, what time is it in England, Dave? And thanks for being active in the group. That's cool. Very nice. Very nice. Get it up. Oh my goodness. So we have an international crowd. Um, oof, yeah. So all right. Well, we won't try to keep you up too late. That's about my bedtime here in the States. So I was in England a couple of years ago, in London mostly, and then a little bit of a Harry Potter trip for my son. But anyway, okay. So most of you probably know who I am. I'm Dr. Orcutt. I'm a orthopedic surgeon here in the States, in Indiana. Thank you. At least we have another one from the States. So I have been an orthopedic surgeon for about 20 years. I finished my fellowship in sports medicine in 2006 and been practicing since then. Board certified, which means that you do an extra training and extra test to confirm that you actually know what you're doing, which is important here in the US. If you're not board certified, you can still practice. Some people would question, why are you not board certified? 2 days post-op. Oh, Ed, I'm surprised you're awake. 4 weeks, excellent, excellent. So anyway, so I do a lot of orthopedic surgery, shoulder being one of them, but shoulder being my passion. Started the YouTube channel about 5 years ago, I think, and just really trying to do a little bit better for being on here. And Ed, that on purpose, no narcotics? I mean, that sounds like a painful proposition, um, considering how much it hurts to have surgery. Sorry, I just adjusted my screen. Hopefully that's not a problem for you guys. Okay, so we're going to get to talk a little bit about the rotator cuff, and then I'll get into your questions. The key thing is you have to understand, what's important for you to understand is that I'm not your doctor. I'm a doctor. I can't truly give you medical advice. I can give you general thoughts and trends. It's not specific for you, but specific for people recovering from shoulder surgery. I've done thousands and thousands of shoulder surgeries, including, but not limited to, rotator cuff repairs and labral repairs and reverse total shoulders. And so pretty much I've done every surgery you could think of around the shoulder. So I think that's important, for the expert to know all the different things. There are people who just do rotator cuff repairs and don't do shoulder replacements, and vice versa. Important to have them all, able to do them all, and therefore I can have a better understanding of which one is better and which was not as good. Okay, so we'll talk a little about the rotator cuff. Everybody knows there's four rotator cuff tendons. Yes. Anybody give me one of the rotator cuff tendons that we often fix? Maybe the most common one that we often fix. Okay. So the most common one that we fix is the supraspinatus, right? There's supraspinatus, infraspinatus. So the supraspinatus is on the top. Very nice. Subscapularis, yes, that's possible too. So the one in the very front, we get this down a little bit. The one in the very front is a subscapularis. The one in the top front is a supraspinatus. That's one of the most commonly injured. And then the infra is just behind that. And then there's one in the way back called the teres minor. Those are the three rotator cuff tendons. And the problem with the rotator cuff and why we actually have to fix it so much is it has a really bad blood supply. So where the rotator cuff attaches to the greater tuberosity, the blood supply is not so good. So we do this a million times throughout our life. We get some damage, and that damage. Sorry, I'm gonna look at Dave. So, okay, yeah, that happens sometimes at range of motion. So we'll talk about that in a minute. So that tendon, that attachment is not very good, and so when you get a little tear, lots of times different places in the body, things heal easier. Like the lateral condylitis, if you ever had pain on the outside of your elbow, that tennis elbow, kind of the same spot where the tendon attaches to the bone. The blood supply is not so good. Supply is not so good. Then when you have an injury, it doesn't heal or doesn't heal completely. Easier for it to re-injure itself and ultimately to create a bigger problem that has to be fixed. Now, unlike the lateral condylitis or the tennis elbow that we don't really work on very often, the shoulder obviously we do a lot. Um, and so the rotator cuff, once it tears away from the bone, and therefore the only way to get it back where it's supposed to be is to fix it. Whereas the tendon is a little bit different in the elbow. So we have to go there and we actually have to stimulate growth. And you've probably seen in a lot of videos where you kind of clean up that area, kind of roughen it up, kind of make it be bleeding better bone so that when we put the rotator cuff back on, it will heal better. We also have different techniques. We have a double row repair where we fix the in two different spots on the greater tuberosity. We have a patch that we can put on the top to help encourage it to thicken, encourage it to heal. So the rotator cuff doesn't heal very well, and so that's another reason why, unfortunately, I have to make a video saying what happens when the rotator cuff doesn't heal and why might it not heal. So we have to understand that the rotator cuff is a very finicky tendon, tears easy, doesn't heal very easy, and that's why we have to be really slow in a recovery. Because if you do stuff too fast, then you're going to disrupt. You'll start getting some motion between the tendon and the bone, and start getting that motion, and then it's destined to fail. So anyway, so that's a little about the rotator cuff and why it doesn't heal very well, and why we have constant problems with it over and over and over again. So let's see. So I'm behind because we were supposed to start at 5, and we didn't start until about 5 minutes ago. So I will open up to some questions, and we'll kind of go through it. But again, the key thing for us is to understand, and I have to say this medically, legally, that this is general advice. This is not true medical advice for you. All right, let's see. 8 a.m. Friday in Sydney. I was in New Zealand in December, so I understand that time. It's a crazy thing that we're behind but ahead at the same time. But yes, I've not been to Australia, but it's on my bucket list. All right, so I'm going to go back to Dave's question. So you guys can you guys see the chat, or can I only see the chat? I think you all can see the chat, right? Bugs, welcome. Zara, welcome. Um, so all right, so Dave, we see you had surgery 18 weeks ago, but my shoulder was better 2 months ago, so that's about 8 weeks ago, or 8 weeks after surgery. Still some pain and some motion not improving. Yeah, and that's a tough one because it's hard to know what that really is, whether that's just slow recovery because it's not that long. Um, so when I think about rotator cuff repairs, I think that I wouldn't do anything as far as imaging or anything like that for about 3 months because I think it takes that long to know, is this really out of the ordinary? Or are you just kind of in the ordinary, just a slower ordinary? Also has a lot to do with how bad your rotator cuff tear was, how many anchors we needed to fix it, what else we had to do. So if you had a really big rotator cuff tear and it takes a long time, it actually may be normal that you're 3 months down the road and still a little stiff or still having some pain. And I do know that typically for people, we're going to have pain, some sort of pain, certainly for 12 months, and probably a little bit of pain for maybe forever. I think that people who have shoulder surgery often don't get back to a place where like it was is if nothing ever happened. That's a rare thing. It happens sometimes, but it's a rare thing. Okay. Ultrasound next week. So so again, I can't tell you specifically, but when I think about this, I think about 3 months not doing well or not doing well enough. If I think there's a good reason, if you really are struggling with range of motion, if my patient is really having difficulty with pain, then at 3 months I might get a repeat MRI. The repeat MRI and a repeat or an ultrasound are two different things, and I think that there's I think England and other countries are more reliant on ultrasound than maybe we are in the U.S. Uh, I do ultrasound guided injections, sometimes the AC joint because that's a small joint to inject, or if I'm going to do the hip injection because it's such a deep joint. Um, I I think if you have a very talented ultrasonographer and a radiologist who's reading it, then certainly that can be helpful. However, I typically, just me personally, have not been particularly impressed with ultrasound. If I really want to know what's going on to the best I can, MRI would be better. If if I get an MRI, the MRI isn't always conclusive, right? You could get it just like even before surgery, but after surgery it's even worse because you can't really see it as well because there's still inflammation even at 3 months, and that's why you wouldn't do it before 3 months. I don't think there's still inflammation there, and so the inflammation can make it difficult. You can see the rotator cuff, but you're also going to see the anchors you use, so it gets a little bit tricky unless it's really obvious, right? And so I think you can tell an obvious re-tear, probably an ultrasound, and definitely on an MRI. But you might not be able to tell a partial thickness re-tear. By the way, which we know if we look at the literature, we know that most people who have rotator cuff repair, especially if it's a bigger tear, they don't get complete healing. They get partial healing, almost like spot welding. Oftentimes that's good enough. And that's probably, I think, part of the reason why we have re-tears and part of the reason why we still have some pain. So it's difficult to interpret that information. So I'm sorry, Dave, for that, but hopefully you get some resolution to the issue, and hopefully it's just a little bit slower than typical, and you don't have to have anything else done. Okay, let's see. Bugs asked, does a biceps tenodesis reduce shoulder stability? So in general, the stability of the shoulder is not a problem unless you have a massive rotator cuff tear or you're younger, just in general. So let's say I'm talking to the crowd that's my age, 50 and older. A 50-year-old and older almost never, not never, but almost never has instability problems. They have pain problems, they have rotator cuff problems, and maybe if they have a massive tear, then they could have some instability. But if you release the biceps, whether you do a biceps tenotomy or a biceps tenodesis, in my opinion, and I don't think there's any studies out there that have really specifically tested for this. There probably is. Actually, I probably just don't know. The 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 biceps tenodesis or tenotomy doesn't affect stability of the shoulder. It is a depressor of the head so much, and that's probably important for throwers. So if you're a young athlete, you don't want, and that's why we try to fix the biceps if we can in younger population. Even in very, very active, like let's say for me, I'm 55, I'm pretty active, go to the gym. I would not worry about stability. Excuse me, I would not worry about stability if I had to have a biceps tenotomy or tenodesis. I'm not worried about. I think I'm a stiff old man, and so I won't be really loose or unstable after that. Hope that answers the question, and you can go ahead and uh, say a question. Can a severe? So I'm going to do the next question. Buzz quick. Can a severe proximal biceps tendon tear benefit or be repaired from PRP? Um, I think there's much better literature on the rotator cuff being able to, the partial thick rotator cuff being improved by PRP. I don't know that there's much information on biceps tendons themselves. It all depends. If it's severely torn, probably nothing is going to help except for biceps tenodesis, biceps tenotomy, in my opinion. Let's see. Zara, you had a biceps tenodesis and a rotator cuff cleanup. So that should be, I mean, it's not going to feel good at first, but that's a pretty good deal. that you didn't have to have your rotator cuff tear repaired. Maybe it was just a partial tear. So that's good. That's good for you. I think in the long run, that's good for you. Dennis Rosette. So can I say your names? I mean, hopefully we're not worried about that. But I'll just say first names for now. Sorry. Will the MRI show any tear in the rotator cuff? Will it show a false negative tear? Oh, so that's what we're talking about, the sensitivity and specificity of MRIs. So MRIs can do both things. I've had lots of times, well, not lots of. In general, the MRI is a good test. But I've had times where the MRI didn't show a tear and they continued to have pain and pain and pain. And so we went in there and there was a tear. I've also seen an MRI that showed, and I went in there, actually the biceps was fine, but the rotator, if you look at the rotator, we look at the ball, the rotator cuff comes across the very front of the supraspinatus at the very top of the subscapularis. That biceps goes right in between those two tendons. It's called the interval. And when it goes in between those two, it's really close to both of them, really close, more so to the supraspinatus. When it's really close to the supraspinatus, the MRI sometimes has a hard time telling the difference. And so I've had instances where it looked like the bicep was torn and it was the rotator cuff, and vice versa. So an MRI can be incorrect. That's very true. And that's why you have to not just go with the MRI, because there's people who have actually MRIs of rotator cuff tears that are not, they're not having a lot of pain. And so we don't ever go on just the MRI. We go on the MRI plus we would look at the symptoms. We look at the actual shoulder, do an exam, and that's why it's really, there's some limitations as far as uh, just talking to someone. Uh, so we need to just make sure that we're not just taking the MRI into account. Hey, there's been somewhere between 28 and 34 people on, so that's awesome. Despite my best efforts to screw this all up and start at 15 minutes later, we appreciate that. Okay. Um, let's see. Okay, so Sean, 43, one rotator cuff surgery on the left, now on the right. Yuck. That's not very strange either. I mean, I've done a lot of bilateral, one at a time. I've never done two at the same time. I don't think that would work very well. You gotta have one to kind of go behind your, you know what. So I think one at a time. So good luck on that. When's the next one coming up? Let's leave that in the chat. Um, 1 week post-op four anchors, shaving bone spur, clavicle, space, biceps tenodesis. The sling given me armed. Yeah, so the sling, so if you have a sling that's wrapped, sorry, let's see if I can bring this down again. Right, you have this and it wraps around you. That's actually more of an immobilizer, and that would be typical of what I would put anyone in after a rotator cuff repair, at least initially, especially because we got the block numbs your arm. You can't feel it for the first 24 hours or 48 hours. I would always put everybody in an immobilizer. But most likely a four anchor tear is a big tear. Some people put in a lot more anchors than others, but I don't know anybody who would put four in if it was a small tear. So good luck, Maria. Just take your time, right? Patience, just like talking at the very beginning of this. Make sure that you're not pushing too hard. Make sure you're kind to your body, and make sure that you're not rushing it. Because if it's a big tear, there is a higher likelihood, right? We can see this in studies. If you have a small tear, you have a smaller likelihood of a re-tear. If you have a bigger tear, you have a higher likelihood of a re-tear. So for anchor repair, just be careful. Dave asked, "Do you talk with your patients post-op? My surgery call rarely answered their phone, almost never calls back." Well, so this is a tricky thing. I do, but oftentimes the patient doesn't remember when I talk to them, meaning the day of surgery. The patient doesn't actually remember, even if I talk to them and I say everything. The anesthesia is still working. They have no idea. They come to the office and say, "I didn't even see you," and they would say, "I didn't see you at all that day," which is interesting because you can't go back to the operating room without me actually seeing you and putting my name on your shoulder. And so, yes, I would talk. I would definitely talk to the patient's family. I guess occasionally, if the family is not there and I can't find anybody, and you are there and you're the patient, I talk to you and you don't remember anything I said, then it might seem that I didn't talk to anybody, but no. And that communication, that's part of the issue with doctors in general, surgeons especially, that we're not really pretty good at communicating. I don't know if you have some sort of way to email or text them or whatever, but keep reaching out. And again, I can't give you specific advice, but I certainly will try to help the best I can. Uh, so yeah, never calls back. That's a problem. That's you're gonna have to try to get in there and see somebody that there might be a physician's extender, a PA or NP that you can talk to, and if they're experienced and they've been in the OR with them, they will be able to answer a lot of questions. I had a great one. So yes. Okay, let's see. Please discuss how tendon can be returned to what nature provides and how to improve the odds. Lucia, I think I need you to rephrase that because I don't exactly understand it. Dennis, glad it's clear. Sunflower, that's a nice name. 5 months post op, pain free, but assist reflection stuck at uh, 150. Am I going to have full recovery? Well, so when someone says full recovery, that's actually a trigger word for me. Full recovery means I'm going to have my shoulder like new, like nothing ever happened, like I'm 16 again. I think it's unlikely for anybody, although it does happen at times, and it's hard to predict who is that's going to happen to, who's not. Um, I think that are you going to at 5 months if you're stuck at 150 degrees? I think you mean elevation. I'm not sure. Um, if you are at 150 degrees at 5 months, let's say I have a patient that they were stiff before surgery. We did a manipulation right before we did the surgery. So they go to sleep, we're moving the arm around, break up the scar tissue. Then we do the surgery. They're highly likely that they're going to be stiff after surgery, despite our best efforts. If that patient then went on and was 5 months down the road, 5 months down the road, they had 150 degrees or 160 degrees. So if this is 90 and this is 180, 150 is here. That's actually not bad. But do I think that you're going to get to 180 if that's what we're looking for? Probably not. I think we my goal is always to be able to do this and this. If you can do that, I think the range of motion is successful. Now we talk a lot about women who try to reach behind their backs, right? So oftentimes men don't notice that much. They reach for the wallet, but they don't go up their back like a lot of women who wear bras. And so the internal rotation is often an issue for them. The internal rotation, so this one behind your back is what we see most often as the last thing to come. So I hope that answers some of the question. Ed, does prep help the healing process after the repair? Um, it's really hard to know what prep you can do. I mean, you want to try to keep your motion, your range of motion, the best you can. You want to try to move it passively, right? Beyond that, I mean, you have a torn rotator cuff, probably a massive one if you had a if you had dislocation. Usually, when you dislocate your shoulder, if you tear your rotator cuff, it's a big rotator cuff tear. So there's probably not a lot other than trying to keep it passively mobile. I think that's probably the best thing you do. I don't think there's a whole lot of pre-op um, prep that will help. Oh, sorry. Maybe I didn't answer that. Oh, PRP in the healing process. Again, PRP for rotator cuff repairs. There is some evidence that PRP can be helpful. Now, a lot depends on There's a lot of formulations of PRP, so I don't think we've quite got to figure out how much PRP platelet-rich plasma is what we're talking about, right? It's you take some for your arm, your blood, spin it down. There's a layer called uh, plasma-rich platelets, so it has a lot of platelets, and then you inject it um, into the subacromial space where the rotator cuff is. I think there's a lot of information that we don't quite know about it. I think there's some interesting studies that show one, it may be able to help partial thickness tears, right? Maybe able to help heal partial thickness tears, or it might be able to help repaired tendons do better. But I think there's a lot more data out there because again, there's the studies are not that similar, meaning that they don't have the same concentration, use the same way. So it's really hard to compare. But I think it's interesting. I think the biggest problem is it's not covered by insurance. At least in my area, it's not covered by insurance, and it costs six, seven, $800. So if you're on a fixed budget, like a lot of my patients are, they're retired. It's hard to tell them it may work, it may not work, and then want to try it. But I think it would not be in general. It's not a bad thing. Just the question is it worth the expense? Um, maybe so. Okay. Maria, I'm sorry you can't sleep in a recliner. How about wedges, wedge pillows? I don't know if you saw my video. When we put this recording out, I'll put a link down below to the wedge. Actually, um, they sent me the wedge. There's a wedge system, Linux. I would say it wrong because it's not the software system. But anyway, they have a lot of different angles you can use, but sometimes you just can't sleep for a while, and that sucks. Tito, hey Tito, how are you? Surgery for slap tear, the best option after 4 months of physical therapy and medication is not helping. Well, I don't know because there's so many other information that you need to know, that we would need to know, specifically the MRI and what the slap tear looks like. If a slap tear doesn't heal, which almost never they heal, unfortunately, if they don't heal and you're still having symptoms, then depending exactly on your age and circumstances, all this stuff. Again, we have a slap tear video too. It's either slap repair, but again, if you're in this group, and if you're in my age group, probably not. Biceps tenodesis, biceps tenotomy, right? Tenodesis, you put it somewhere else. You put it up high, you put it in a little middle, put it below. I don't think it really matters where you put it. Or tenodesis where you release it, and that's okay if you're a low activity person. So maybe it's the right answer, but there's a lot more information that you need to talk through with your doctor. All right, Dennis. People are concerned on the possibility of thrombosis in the shoulder. Serena and Victor W are examples. Are there weekend athletes and also the same risk? Yeah, I think that's a super rare thing, and I don't know. I think there's some more information that we don't understand. I've never seen it in my office in 20 years, of an acute thrombosis. Again, it doesn't mean that I couldn't have missed one, I guess. Doesn't mean it doesn't happen. I just think there's like a thousand times more likely that you're going to tear your rotator cuff, your biceps, than have thrombosis. So I'll look into that. Let me write that down. Maybe we can have an article or whatever. And so, oh, you guys know that I have a newsletter that I send out every week. I'll link to that down below too. And we have a private Facebook group. It'll down below as well. Let me look into thrombus and let me see what the best venue would be to get that information out once I research it. So, good question. I'm not particularly worried about it, but doesn't mean it's not something we should think about and talk about. Is the risk half as the pros or much, much? I think much less, way less. Um, Tendon strength after repair. Yeah. So the tendon strength a lot has to do with how big the tear was. Lushar asked, what is the tendon strength like after it's fixed and healed? Tendon strength, it has a lot to do with how bad the tear was, how good your tendon was, right? So if you have let's say your normal tendon is this thick, right? And you over time have thinned out that tendon, and that's part of the reason why you tore it. And now the tendon is torn. We fix it. If we repair a thin tendon, then obviously it's not going to be sturdy as if we repaired a thick tendon. That's part of the reason sometimes we put the graft on top. So a lot depends on that. I still think that a tendon that's been repaired is probably not quite as strong. I don't know what exactly that means. I think the key thing is to get your motion back, get your strength back, do your rotator cuff exercises, right? Do the rotator cuff band exercises. Continue that. I think it's just like exercise in general. People will say, "Well, when do I have to stop doing this?" Well, probably never, right? When do I stop my shoulder rehab? Well, probably never. You should always be doing rotator cuff repair, rotator cuff tendon exercises. I should be doing rotator cuff tendon exercises, and I've never had a rotator cuff tear, as far as I know. That was a painful shoulder, but hopefully it's not torn. So I would say you should continue with those exercises for the rest of your life if you want to have the best shoulder you can. Dustmaker, welcome. Thank you. We did respond a couple times to your comments in other videos. Do you know why the surgeon would have used Arthrex titanium corkscrews instead of one of the composite materials? Um, I heard titanium will do something. Titanium won't do anything. I mean, what won't happen is it won't dissolve, right? It won't. I think you maybe met rust. It won't dissolve. It won't do anything. It will just be there, right? And there's nothing wrong with the titanium anchor, except the problem that reason why we moved over to absorbable anchors is because if we have to go in and fix another rotator cuff, say God forbid you have another rotator cuff tear, you go in there and that anchor's still in the bone. When you take the anchor out of the bone, there's a big hole where the anchor was, and so it's hard to put another anchor in. You have to be a bigger anchor, or you have to make some adjustments. If you have a plastic anchor in there or bioabsorbable anchor composite, they begin to dissolve and they have much less real estate that they take up. So I don't know why you would use that necessarily. Most people don't. I'm sure there was a reason. I just don't know what it was. And sometimes sometimes if we use um, metal anchor, there's a reason. It may be a specific anchor that does something better than others. I'm not really. Arthrex is a huge name, so they have lots and lots of products. So I'm not really sure why. Okay, 18 VM a day, Dave. I'm sure it is still tender. Normal is all a relative term. Um, so we're coming up at 5:45, and actually, unfortunately, that is my hard stop. So it's 5:44. So I'm going to stop. If you would like to do this more often, please put in the comments, yes, I'd like to do more often. If you like this channel, subscribe to the channel, please. That'd be nice. And let me see if there's anything else here. Let's see. I think that's it for now. So it's a good format. I think it's a better format. I think you actually be able to maybe understand things a little bit easier. So if you want for me to do this again, hopefully on time next time, put in and say yes, yes, awesome, thank you, and I appreciate your time. I know it's 5:45. Also, oh, if you can, also in the comments in the chat, that's fine, either one. Say what time Eastern time would be better because that matters. For me, because I can be pretty flexible. I can do it later. I can do it earlier. So if you think that there's a better time, we have 31 people on right now. If there's a better time where we get 50 people or 100 people or whatever, and then we're gonna have to figure out how to answer the questions because there's gonna be a ton of questions that I can't quite get to. So let me know. And thanks again. Have a good night, good weekend. Remember, be patient, be kind to yourself. It's a long road. Thanks.